We'll now discuss clinical toxicology. Paracelsus already in the 16th century said, alle dingen sind Gift, allein die Dosis macht das ein Ding kein Gift ist. Everything is a poison, only the dose determines if it's a poison or not. There are many types of intoxications. The most important is the tentamen suicide. That means that the patient takes an overdose to take its own life. Also, somebody can try to poison another. That can be an attempt to murder. We have children taking something of a household product, of a drug from a parent, of a grandparent. Drugs in overdose are taken by adults in need for attention. Those are usually not lethal overdoses. Or adults administer drugs to their children in need for attention. Poisons can be taken by mistake, for example, when they are stored in a lemonade bottle. And drugs can be put in a drink for an attempt to rape. Other types of intoxications consist of, for example, of confused elderly patients taking too much drugs. Pharmacists can make compounding errors. Physicians can make prescribing errors. You can ignore an impaired renal or hepatic function and not adjust the dose so a patient gets intoxicated. You have drug-drug and food-drug interactions. And there can be accidents in a house, for example, insufficient ventilation with a stove or a gas heater, resulting in carbon monoxide intoxication, and there are lots of other intoxications. Analytical toxicological investigations can be qualitative and quantitative. Qualitative analysis are usually carried out by immunoassay. They are commercially available and they are validated. But the answer is only yes or no. Is the drug present or not? And usually there is no concentration reported. So beware also of the lower limit of quantitation. A drug can be present but cannot be measured by the immunoassay. Immunoassays usually react with groups of drugs like the amphetamines, benzodiazepines, barbiturates, tricyclic antidepressants, and not with an individual drug. And further, the immunoassays usually use urine, so there's no relationship of a concentration and clinical signs. On the other hand, quantitative analysis measure on the one hand the identity and the concentration of a drug. Quantitative analysis can be used for urine and for blood, and the blood concentration is usually related to clinical signs. Quantitative analysis are usually based on chromatography, and they are developed in-house, so they need a full analytical validation. Why do we carry out a toxicological investigation? The most important reason is that we have no clear cause for the clinical picture of the patient. For example, a patient can be comatose, we have no clear reason for the coma, so we are looking for drugs that are probably causing the coma. There can also be a risk reduction. A patient can be overdosed, for example, with drugs that cause convulsions in combination with a benzodiazepine that can mask convulsions. So you want to know if there's a combination of drugs and which drugs the patient has taken. There can be a confirmation of a suspicion that may help the treatment, that can give a prognosis of the duration of the treatment, depending on the elimination rate of the drug. You can perform a toxicological investigation to calculate the dose of an antidote and the duration of antidote treatment. You can also carry out a toxicological investigation to have a limitation of other diagnostic tests. Further, a toxicological investigation can help psychiatry for the aftercare of the patient, to establish the brain death of a patient, to exclude drugs as a cause of brain death, and to make a choice for the type of treatment. For example, antidote treatment like single-dose charcoal, repeated dose charcoal, dialysis, and other types of forced elimination. And you can perform a toxicological investigation for legal reasons. Let's present a case of a patient who took a paracetamol overdose. A patient took, according to his partner, in the evening at 10 o'clock 70 tablets of 500 milligrams of paracetamol, and now it's midnight. What do you do? Let's first calculate the dose of paracetamol ingested. 70 tablets is 35,000 milligrams, is 35 grams. What is the weight of the patient? Suppose the patient is 70 kilograms, then he took 500 milligrams per kilogram body weight. From the literature we know that 150 milligrams per kilogram is potentially toxic, and paracetamol will give irreversible liver damage if untreated with a fatal outcome. So 70 tablets is a potentially lethal dose. Based on the anamnesis, you start with the antidote, and the antidote is N-acetylcysteine. You also take a blood sample and let it be analyzed for the concentration of paracetamol. You judge the risk for hepatic toxicity based on the analytical result and the rheumatoid nomogram, which I will discuss later. And then you decide whether the N-acetylcysteine must be continued. On this slide we see the rheumatoid nomogram for paracetamol or acetaminophen toxicity. Acetaminophen is the American name for paracetamol. On the horizontal axis you see the time post-ingestion. On the vertical axis you see the paracetamol concentration. There are 4 areas in this graph. Left from the 4 hours post-ingestion line, there's no information about the relationship between paracetamol toxicity and the concentration. Right from the 4 hours line, at the bottom you have the concentration that most likely won't result in toxicity. You have a possible toxicity area and you have a probable toxicity area. The decision to treat is when the measured concentration is above the line that is given for the possible toxicity. Another case is the case of an acute intoxication. A young man, 27 years of age, came to the hospital together with his sister. He is somnolent, disoriented, in speech and aggressive. His sister tells that he has shown a handful of pills he was going to take. His vital signs are a body temperature of 37 degrees, a heart frequency of 120 per minute, blood pressure of 100/60, he breathed 22 per minute, his skin is warm and dry, his mucous membranes are dry, his pupils are widened and do not react to light. What has he ingested? In this case there are some clues present which give an indication of what he probably has taken. We call that a toxidrome. Toxidromes are clinical signs and symptoms that are important for successful recognition of an intoxication. The most important toxidromes are the sympathicomimetic toxidrome, anticholinergic toxidrome, hallucinogenic toxidrome, the opioid toxidrome, the sedative hypnotic toxidrome, the cholinergic toxidrome, the withdrawal toxidrome, and the serotonergic toxidrome. This slide and the next two slides summarize for the different classes of toxidromes the examples of the drugs that cause the toxidrome, the vital signs accompanying the toxidromes, what the pupils do, and what other findings may be. Here you see the sympathicomimetic toxidromes with examples, vital signs, pupils and other findings, and the anticholinergic toxidrome. Here you see the characteristics of the hallucinogenic toxidrome, the opioid toxidrome, and the sedative hypnotic toxidrome. And this last slide summarizes the cholinergic toxidrome, the withdrawal toxidrome, and the serotonergic toxidrome. For more information, I refer you to the reader. Other clues leading to possible intoxications are found on this slide. For more information, again I refer you to the reader. Next I will give you some numbers about intoxications. For example, the region The Hague, with about 800,000 inhabitants, has 2,500 intoxications per year. For 800 patients, there are one or more analyses performed, of which 400 screenings, and these drugs have been found. 29% of the patients were intoxicated with psychotropic drugs, 18% with paracetamol, 18% with other drugs, 15% drugs of abuse, 9% alcohols, 6% midazolam, and 5% other analgesic drugs. Of these analytical findings, only the paracetamol and the drugs of abuse can be found by commercially available immunoassays. All other drugs, about 75%, cannot be found by commercial assays, so you have to use in-house developed assays to solve the other intoxications. The most widely used in-house developed method is the HPLC DODR or STIP screening process, and STIP means Systematic Toxicological Investigation Procedure. This is a Dutch development. This process consists of taking a blood sample, centrifuge it, add an organic solvent, shake and centrifuge again, separate the organic layer from the water layer, evaporate the organic layer and dissolve the extract in a mobile phase. Then you inject the dissolved extract in an HPLC system, you record the chromatogram, you record the spectrum in every point of the chromatogram, and you interpret the data and report. The interpretation of a STIP chromatogram consists of, on the one hand, looking at the retention time, and on the other hand, look at the spectrum in every peak. And the combination of retention time and spectrum gives a clue of the drug that has been identified. Every laboratory that analyzes drugs must participate in a quality control program. Also, for toxicological investigations, there's a quality control program. Samples are distributed with unknown composition. They are with a realistic clinical case, as laboratory You have to perform an analysis and do the interpretation, and you have to give a report of your findings and your advice to the proficiency testing organizations. You get feedback and a judgment about your findings. This is the end of the lecture about applied pharmacokinetics, therapeutic drug monitoring and clinical toxicology. I hope you've enjoyed this lecture, and if you have questions, you can always contact me.